So, Chapter 19 starts our very brief opportunity to look more specifically at some microbial infections and different systems that they occur in. I cherry picked here, right? We've got a few chapters that I totally skipped because we don't have time. And I tried to pick a few chapters that I thought are really prevalent disorders, things you're definitely going to come across. And then even within this chapter, you'll see that I'm really focusing in on some of the illnesses and not covering absolutely everything in the chapter. I will say your book does a really nice job with tables, kind of laying out each of these illnesses, whether the microbe is bacterial or viral or fungal, what it is about the microbe, right? What are its virulence factors? And so again, just consider what you need as far as where your education is taking you. I know you don't get to keep the book, but if this would be a time where maybe you want some of those tables, think about making a file and cutting and pasting them in, something like that. So I'm just going to cover some of the illnesses, and that's what I will test you on, but absolutely there's other really important, really fascinating stuff in these chapters. So feel free to take the time and go through and explore some of those things that interest you as well. Okay, so let's jump into these respiratory infections. So again, hopefully, I think you've all had A&P at this point. So we've already talked in anatomy physiology about the difference between the upper respiratory tract, lower respiratory tract, and really the larynx being kind of the terminal end of the upper respiratory tract, and then everything below that. So the trachea on being lower respiratory tract. So if you need a quick review anatomically of where these things are taking place, this will help you out. This is a really nice image trying to remind us of what this mucus elevator looks like in the respiratory tract. So in particular, the trachea has this really nice pseudostratified ciliated columnar epithelium, right? So all of these cilia on the surface, of course, are meant to propel bacteria up and out of the respiratory tract. Particularly, they'll get captured in some of the mucus that the system is producing as well and get removed. So that is a really important defense that we see here in the respiratory tract. So, and this is fun, right? What we're going to see, we'll definitely notice some themes. There are a lot of, unique things about these different diseases, but when you're in the respiratory tract, most of those disorders are going to be transmitted through respiratory droplets and aerosolized particles. So, and I think we already talked about, well, I don't know which class I talked about, right? These bigger particles would probably be considered droplets. They're going to fall out of the air fairly rapidly. And then some of this finer mist might be aerosols. And that's one of the big questions with COVID, right? Is it spread by droplets? And so as long as we stay 6 feet away, we're fine. Or is there actually this aerosol transmission, which would mean that those pathogens could actually be hanging out in the air for quite a while, even after, say, the person spreading it has left. And indications at this point are that COVID does spread through aerosols. So we are going to start here with streptococcal disease. So again, remember from lab, we've looked at this idea of the strep being a description of bacterial arrangement, right? So a long chain. Cocci then refers to the spheres. And so what we're looking at here is a large, diverse group of microbes that can cause a range of diseases. It can be from a very mild infection to quite severe disease. These are gram-positive bacteria. And again, usually you see them in a chain. Sometimes it'll be pairs. So one of the, where do I want to go here? Okay, so this is looking at a characteristic streptococci here. And a few things that they're pointing out here, specific proteins that are on their surface, right, that our immune system might recognize. This M protein they're pointing out is playing a role potentially in adhesion in the host cell. Some of these components, like this lipotecoic acid, I believe, part of this bacteria's defense from us breaking it down. One of the things that we saw in lab, right, when we used that sheep blood agar, or Patty set it up for us, this sheep blood agar. This is how streptococci were classified for a long time, based on the pattern of hemolysis that they exhibit. And so I thought this was a really nice, clear picture, and they drew it with the letters, right? So beta hemolysis is where we see that complete clearing, right? It's completely hemolyzed or destroyed red blood cells, and it leaves that clear ring in the agar. Alpha, right, that's this guy over here. Alpha hemolytic streptococci do partial hemolysis, and so the agar turns kind of this greenish color. And then non-hemolytic or gamma hemolytic, it really doesn't affect the sheep blood agar. So they grow on there, they like the nutrients, but they're not actually destroying red blood cells. And so this was a way to kind of distinguish what groups you're working with. Since then, they've chosen to separate them a lot more based on some of the glycoproteins on the surface of the cell. And so now strep is typically separated into group A and group B, and it has nothing to do, there's no nice pattern of which hemolysis fits in there. So for example, group A, probably the most common strep species that you'll run across is that strep pyogenes, and that is a group A streptococcus, but that's beta hemolytic. That's not confusing at all. Right, and that's the really common causative organism of things like strep throat. Group B strep, we don't see as much of. Really where it becomes a concern is in newborns. So there's a strep agalactiae, which is a group B streptococcus, and that's the one that's serious in newborns. That's also beta hemolytic, right? So that the hemolysis has fallen out of favor somewhat, and we're more likely to classify them based on, again, this carbohydrate on the outside surface. So, okay, so let's look at what these bacteria can do. So this is a picture showing streptococcal pharyngitis, right? Inflammation of the pharynx. You and I know this as strep throat. And again, this is going to be caused by a group A Streptococcus, and these are among the most common organisms, most common human pathogens. Okay, often people can be asymptomatic and just carrying these bacteria around, and sometimes, of course, they're also disease-causing. Again, the most common causative organism of strep throat is that strep pyogenes. It's a group A Streptococcus that's beta hemolytic. It is transmitted by respiratory droplets. Once you manage to inhale those, right, and they attach in your throat, the cells are growing, they start secreting these toxins. That's what's causing all this irritation in the throat. That M protein that they were pointing out in the previous two images ago, this is what really helps the bacteria adhere to the pharyngeal tissue. And also really slows down phagocytosis, right? So it's going to make it harder for macrophages and things like that to step in here. And so sure enough, your signs and symptoms, we have this inflammation of the oropharynx, the tonsils you see here on both sides, really inflamed, swollen. This person has a sore throat. They're going to have a fever, very likely a headache. The redness in the throat, and particularly these kind of white pussy patches, is really characteristic. So the reason that this is such a big deal, right? Because often strep pharyngitis can actually be self-limiting. It could cure itself, or your body can catch it and knock it out. But the problem is there's some really severe complications if it's left untreated. So this scarlet fever, they're showing you here this rash that develops. And notice this is actually based on a toxin that the bacteria produces. And your book had a really interesting tidbit that I actually hadn't heard before, and it makes way more sense that to get scarlet fever, the Streptococcus that you have inhaled actually needs to be infected with a particular phage. And I just thought that's so crazy, right? So most strep infections don't lead to scarlet fever. The only way they lead to scarlet fever is if the bacteria has been infected by a phage, right? And that virus is actually telling the bacteria how to make this toxin. I thought that was really interesting. There's also the possibility of the development of rheumatic fever as well as glomerulonephritis. These are both considered immune system mediated, meaning that your immune system is attempting to attack the strep pathogen, and then it seems like maybe a case of mistaken identity. The antigen that your immune system went after looks similar enough to some other structures that we actually start attacking ourselves, right? So rheumatic fever, particularly the heart valves, this is problematic if your own immune system starts going after those tissues. So this can lead to stiffening of those valves or injury to those valves that's going to make the heart's functioning harder, right? And again, that may not be something that's problematic until much later in life, but the damage is done. The same glomerulonephritis, this is inflammation taking place in the nephron, that microscopic portion of the kidney where urine formation is taking place. And this also then can be pretty problematic. It can damage the filtration membrane and lead to lifelong problems with the kidney. So even if you think of strep as not that big of a deal, it is something that's worth getting checked out. And they point out that we have this rapid strep test, right? So very quickly at a doctor's office, they're able to identify that microbe. They also pointed out that there's plenty of false negatives, and so it's fairly common to run to plate out that sample and do a test that's going to take a little bit longer just to confirm the diagnosis there or lack thereof. Okay. So pertussis, this is one that I chose to go ahead and talk about because this is one of those diseases that we often think of as already being gone, right? This is an old-fashioned disease. Who gets whooping cough anymore? But in fact, there has been, I want to say probably in the last 10 years, quite the resurgence of pertussis. Some of that is probably due to vaccination wearing off. They're now recommending basically a booster for pertussis, and then probably a role also for folks who aren't getting vaccinated in the first place. And so this is one of those ones that I think we talked about with vaccine wars, where it's like, yeah, we don't even think this exists, and it can be really bad. This can be deadly. And so here we see Bordetella pertussis hanging out, these yellow guys hanging out at the base of the cilia in the upper respiratory tract. Right? This is an upper respiratory tract infection by a gram-negative bacillus. Highly contagious, right? It's spread through respiratory droplets. And the Bordetella pertussis, really, it adheres to the cilia, right? It aggregates. We see this whole clump of them there. And it produces a cytotoxin. So it actually paralyzes these ciliated cells. That, of course, impairs the movement of mucus, leaving your patient open to other things like pneumonia that we'll talk about here soon. And so there's a couple different stages of someone who's developed whooping cough. Stage 1, you wouldn't really know that this is what you had, right? So it starts out like a lot of different respiratory tract infections, kind of with that general malaise, just not feeling good, maybe a low-grade fever. And then the individual's cough is going to become increasingly severe. In stage 2, really, the breathing becomes really labored. Cells and mucus are accumulating in the airway, right? So lots of mucus accumulations, basically pus accumulation. And then the cough changes into what they call paroxysm. It's this rapid fire staccato cough on the exhale. And then you have a forced inhalation, but the glottis isn't opening all the way. The glottis is like your vocal cords. And so you get this whooping sound. Now, previous experience tells me that I can't play this video for you as I'm recording, but I will show it to you in class. But basically this paroxysm, right? A staccato cough followed by a whoop. I'll do my best. It's like and so the video is better, but it's a very characteristic cough. This is really labored, right? It's basically someone trying to gasp for air between these coughing fits, and it does become exhausting. I actually had an adult student, it's been a few years now, maybe 5 years ago, who told me that she actually contracted whooping cough a couple years before that, and she coughed so hard that she broke a rib. Like, it's not fun. The other thing that happens is because those epithelial cells with the cilia were actually killed, the convalescent period on this one is actually quite long. So they refer to it as the 100-day cough. So you have like kind of sporadic coughing episodes for up to like 100 days until all those cells are actually able to regenerate. So this is one, right? It does respond to antibiotics, but there's also a vaccine, right? So it was the DPT, and that is the one where there was actually dead pertussis, right? So the P is for pertussis, diphtheria, pertussis, and tetanus. And this is one that actually did contain thimerosal as the preservative. Now you'll much more commonly see the DTaP, so diphtheria, tetanus, and I believe it's attenuated pertussis. It's basically extracts of pertussis. It's not a whole cell vaccine anymore. And then, of course, the Tdap is the booster. And so typically you're getting that to protect you from tetanus. But now we're pretty glad that the side effect of that is also more protection against pertussis. So we'll watch this little guy in class. So tuberculosis. A couple of these are just classic respiratory illnesses, right? So tuberculosis, I can't move myself. I don't know why. Okay, we'll just stay there. Tuberculosis, the old-fashioned name for this one, right, was consumption. So that would be like, I don't know if you watched Dr. Quinn, Medicine Woman, right? Somebody would come out from Boston to out west for the clear mountain air, the dry mountain air to try to recover from consumption. So it's caused here by this little bacteria, Mycobacterium tuberculosis. And this is one of those pathogens actually that, if you remember Robert Koch, this is one of the first pathogens that was actually identified by people, and this was by Koch back in the late 1800s. It is a bacillus. They don't really use gram staining on this one. Don't worry, it's not on your unknown list. This one, the gram staining is kind of iffy, but there is a really easy staining procedure. It's called acid-fast staining, and that's going to give a good indication that this is the bacteria that we're dealing with. It basically, it has this extra waxy coating on the bacteria that helps protect it, and that makes it so that the gram stain technique doesn't really work. Again, exposure here from aerosolized droplets. Typically, you need multiple exposures. Really where you'll find tuberculosis is in crowded conditions, people who have malnutrition. Both of those are really going to help the tuberculosis establish itself. And so what we're looking at here in this x-ray, I know we're not experts at reading these, I am not either, but what we're looking at, you shouldn't see these kind of white opacities. these opaque areas or these places where the x-rays aren't going through. So that's a good sign that there's some kind of scar tissue or calcification going on in the lung, which is exactly what happens here with tuberculosis. So even individuals who actually get tuberculosis, only about 5% of the infections are actually going to end up leading to clinical disease. So they'll talk about someone who has a primary infection. The infection stops, the lesions in the lung heal, they'd be completely unaware of this infection. They would have a positive Mann-Tau test, a positive test for tuberculosis, and in some of them it would then become what's considered latent TB, meaning that that infection could kind of emerge later in life. We've got about 2 billion people worldwide that have this type of infection. Again, most of them never develop into an active infection, but it is concerning if you have this latent tuberculosis that particularly at some point, if you're immune compromised, that this could be problematic. Definitely something we see in people who are HIV positive. Tuberculosis is really bad. I think I have a stat in here somewhere, but it's like 70 to 90% of AIDS patients die in 1 to 4 months once they've contracted tuberculosis. So then if you think of it the other way, if they have latent tuberculosis and they acquire HIV, that's also going to be a pretty quick downward trend. So with clinical tuberculosis, right, that's what we would consider the active disease. That's when those people are actually really transmitting it to others, right? So latent tuberculosis, you are not infectious, but if you do develop clinical tuberculosis, you can be transmitting it. These individuals, they're going to start having this chronic cough, chest pain, a high fever, sputum, right? All these thick accumulations coming up out of the lung. And what's actually going on in the lung is the formation of these tubercles. That's a hard nodule that gets formed because the macrophages, let's see if I have don't have any macrophages on here. Macrophages are trying to wall off the bacteria. And so what ends up happening, what they're showing you here, all these blue cells, these are fibroblasts. So they're coming in and actually like laying down connective tissue. This will often calcify. Neutrophils come in trying to get after, here we see, right, actual bacteria. So how do I say, the immune system is helping, right? It was unable to kill them, right? Macrophages actually engulfed the bacteria and the bacteria just multiplied inside of them. And so now we're trying to like wall them off with all this kind of scar tissue, right? Connective tissue. And then neutrophils come in guns a-blazing, and they'll start trying to destroy them as well. And that's when you develop what they call caseous necrosis. Caseous refers to cheese. Sounds awesome, right? And so the lung, big picture here, the lung is damaged, right? So here we see that same necrosis, the granuloma cells, this would be the scarring. And so that's really what's showing up on this x-ray. So that's not great. But it actually can get worse. So there's also a form of clinical tuberculosis called miliary tuberculosis, and this refers to millet, which is a type of seed. And so miliary tuberculosis is when this tubercle actually breaks open and the bacteria can spread through the blood, right? And now it's heading for other tissues, and you can get these tubercles kind of throughout the body, and they start growing and consuming the body, which is why it was referred to as consumption. So for diagnosis, right, the Mann-Tau test is this tuberculin reaction test. So you're actually injecting a small sample of purified protein derived from tuberculosis, right? So not the bacteria itself. And then they're just looking for the amount of swelling that takes place. And so this individual indicates that they've had some sort of exposure to tuberculosis. Sometimes it's from vaccination. Other parts of the world get vaccinated against tuberculosis. I believe that you can actually get tested enough that eventually you will have this reaction as well. And so then typically following that up, anyone who has a positive reaction there is going to have to get a chest x-ray to show that they're not in any form of clinical disease. All right, there are antibiotics, but as you read in the book, it's very stubborn. There are forms of multi-drug resistant tuberculosis that are becoming more prevalent. I think we watched, that might have been our first movie, right? The Russian prison system has all this MDR, TB, months and months of treatment. I think your book even indicated like 2 years worth of antibiotic treatment to try to get rid of them. It's just such a slow growing bacteria. And remember, a lot of our antibiotics work on, even like penicillin, it's working on destroying the cell wall in bacteria that are growing, that are metabolizing. And so it grows so slowly. And that's a big reason why these antibiotic treatments are so long. Again, there is a vaccine. It's not widely used in the US. It sounds like there's some side effects, but in parts of the world where this is more common, right, healthcare professionals in more risky areas will get vaccinated. All right, pneumonia. So pneumonia is really just inflammation in the lungs. And so I do want to point out that this can be of many different origins, right? Bacterial, pneumonial, fungal, even chemical, right? So if you inhaled some chemicals, that could lead to inflammation in the lungs. But typically, what we're talking about is a pathogen-oriented and particularly pneumococcal pneumonia. And so that's what they are showing here, right? Streptococcus pneumoniae. Let's see. Oh yeah, so bacterial pneumococcal pneumonia is about 80% of cases. So Streptococcus pneumoniae is the most common causative organism, gram-positive diplococci, right? See these two together? So that guy shows up pretty easily. Again, keep in mind, typically this is a secondary infection, often not primary. Very, very commonly secondary infection. So someone has influenza and then develops pneumonia, right? So the streptococci then say like, hey, this looks great. Our patient is immune compromised. Let's get in there. So typically when we talk about pneumonia, right, community acquired, there's the pneumococcus, right, pneumococcal pneumonia. There's other causative organisms. If you've heard of Legionnaire's disease, organism called Legionella, that can lead to pneumonia. Haemophilus influenzae, there's a vaccine for now, so they're saying that's less commonly the cause of community-acquired pneumonia. Hospital-acquired pneumonia is also becoming more common, right? This is again, as a secondary infection, people in hospitals are pretty sick, right? And so not unlikely to develop this secondary infection. Lots of different organisms can cause this. They are often multi-drug resistant and fairly aggressive organisms. So hospital-acquired pneumonia is not good, right? In fact, people who are put on ventilators, ventilator-associated pneumonia is a form of hospital-acquired pneumonia. And it actually has something like a 50% mortality rate, right? It's not a good thing. So transmission-wise, right, we're looking at aerosolized droplets, sometimes contact, right? It can live on a fomite and maybe pick it up that way. And it's often actually endogenous bacteria, right? This can often be an opportunistic infection, right? You had a primary infection, influenza. Secondarily, you have this opportunistic infection by these microbes. Because about 50% of healthy individuals have this bacteria in the upper respiratory tract. So things like malnutrition, smoking, a viral infection, being on immune suppressants, right? Any of those could lead to this situation. This patient is going to have a high fever, sharp chest pain, difficulty breathing, rust-colored sputum. So a few signs and symptoms you might look for. Penicillin is the antibiotic of choice, but we are seeing increased resistance. And then, of course, penicillin is one of those antibiotics that quite a few people are allergic to. So there's some other classes of antibiotics that are fairly effective here as well. There's also, if you guys have heard of walking pneumonia or maybe had walking pneumonia, this is considered an atypical pneumonia. Different causative organisms, Mycoplasma pneumoniae is the really common one. This is pretty common in college settings, people living in close quarters, not near as severe, right? It's considered walking pneumonia because you're up and about. Okay. Oh yeah, so walking pneumonia, fever, cough, headache, muscle pain. Again, usually responds to antibiotics. Okay. Anthrax. So this is a fun one, and I don't think your chapter didn't even have this. It probably put it in with another group of organisms. Causative organism here, Bacillus anthracus. So it is a bacillus, right? And it is a spore-forming bacillus. So that's actually what you're seeing here. What look like little air bubbles. Those are endospores that are being formed. Gram-positive bacillus. It also has a really thick capsule that helps protect it from phagocytosis. It produces several exotoxins. It's kind of a mean bacteria. It is considered enzootic. It's endemic in a lot of animals, particularly large domestic herbivores, so things like sheep and cattle. It also can survive in the soil, right, in the endospore form for a really long time. So for most of us, we're not at high risk of developing anthrax, but people who are maybe like shearing sheep, right, or ranchers would have a much higher chance of developing anthrax. And really, you can get it 3 different ways. So there's cutaneous anthrax, which makes up the majority of all cases, right? So if you come in contact, if you have damaged skin that comes in contact with something like a contaminated animal product, right, a hide, or you were helping, deliver a cow or something like that. So it becomes this kind of pustule of black necrotic tissue, and then it can invade adjacent lymph nodes, and it's about 20% lethal if left untreated. Treated, right, penicillin, ciprofloxacin, they work really well. But that rancher needs to actually have this looked at. Probably more concerning, inhalation anthrax or intestinal anthrax. Intestinal anthrax, this you would get by eating contaminated, undercooked meat, ending up with like this inflammation in your intestines, right? Nausea, loss of appetite, vomiting, fever, abdominal pain, vomiting blood, severe diarrhea, right? It starts to get worse and worse. And again, a really high mortality rate. If not treated, up to about 50% mortality. The worst one that you can get is inhalation anthrax. So this would be if you inhaled some of the spores, right, that were in soil or on the wool of that animal, something like that. This is usually fatal without early treatment. So the spores get inhaled. You start out with kind of cold-like symptoms, but it progresses to severe breathing problems and shock. And really the problem here is treatment for inhalation anthrax needs to happen pretty early, right, when you probably just think you have the common cold. There is a vaccine against anthrax, but typically it's just going to be like veterinarians or livestock workers who would get vaccinated against that. I feel like we talked about anthrax. Did we get into the 2001, someone mailed it? I feel like that was this class, right? So it has potential use as a biological weapon. Yay. Okay, influenza. So we've all become probably way too familiar with this now, right? That the pictures from the influenza epidemic in 1918, so about 100 years ago, was the last major epidemic in the US, and it was caused by a strain of influenza. Influenza is highly contagious, again, airborne respiratory droplets. there are multiple viruses in this family of viruses. They are all, there we go, they are all enveloped viruses, right? Which means you can actually kill them fairly easily, clean them off surface, off your hands. They are all single-stranded RNA viruses. And then one of the other kind of important classifications here we talked about back when we were just talking about viruses in general are these spikes. So this hemagglutinin spike, the H spike, that really helps the virus attach, right? A glutamate attached to host cells. The neuraminidase or N spike that really is important in after the virus goes through replication, the N spike helps it release from that host cell. So there's actually 3 different groups of influenza. Influenza A, I guess I can go to this one, infects many different animals. So here we see, ducks and pigs and humans, and it's not just ducks, poultry in general. And when we talk about this virus, we name the different subtypes based on those H and the N surface proteins, right? So H1N1, H3N2, if you're looking at, what strains are included, say, in the influenza vaccine. Influenza B is less widespread. It's only in humans, but we had been vaccinating against that as well. Influenza C, we almost never talk about. It's really just a mild respiratory illness. You'd probably call it a cold. So every year, and you guys know this because you're looking at vaccines, looking at getting vaccinated. If you're working in healthcare, you're probably getting the flu vaccine every year. And it changes every year because the different strains of flu that are circulating and evolving. So influenza changes in 2 main ways. There's something called antigenic drift, and that's going to be when you have these small changes, maybe point mutations in that genetic code that give it some sort of advantage. And it just makes slight changes in these surface proteins. So what that means is it makes it a little harder for your immune system to find it, but usually you kind of catch on, right? So you can get sick from this new strain, from antigenic drift. You can get influenza every year, yay, right? Because it's just different enough that our immune system can't catch it before it makes us sick. What's particularly problematic, though, is sometimes influenza changes by what's called antigenic shift. And that's what they're showing here in this picture, where you have this abrupt major change in spikes. And this is what happened with the swine flu outbreak in 2009, I believe is the year, right? So here we're showing, okay, there's a duck version of the influenza virus, right, all in blue, and then there's a human version of the influenza virus in orange. They both seem to have infected a pig at the same time. And so you were able to mix the genetics there. And your book actually did a really nice job of describing this. But what we end up with is a kind of a novel version of influenza, right? So here we say, well, it's a human influenza virus, but now it has a spike that the human immune system has never seen before. It's a duck spike. And so this is when we see people getting really ill from it because their immune system isn't catching on as quickly. So with influenza, typically it's a fairly sudden onset of symptoms. The incubation period's pretty short. Usually it's 1, maybe 4 days. And then you have this fairly sudden onset of chills, fatigue, headache, muscle pain, fever, up around 40 degrees Celsius. That's a pretty good fever, high fever, a severe cough. Some people have a sore throat, nasal congestion going along with that. Now, influenza doesn't cause, how do I say this? A lot of influenza deaths are actually from a secondary pneumonia, right? And I don't know exactly how they sort that all out, right? On the death certificate, does it say influenza? Does it say pneumonia? Either way you look at it, in the US, it's usually around, your book lists 20 to 60,000 deaths a year due to influenza, which is shockingly lower now that we're looking at COVID death rates, right? It sounds like a lot of people until you hear we're at 200, and I think today I saw 229,000 deaths in the US in the last 6 months. So, other things that occur as a side effect of influenza, it's pretty rare, but there's a disorder called Guillain-Barré syndrome, where you actually get immune system damage on nerves. It can result in paralyzation. This is a temporary paralyzation. Most people are going to recover from that, but that sounds pretty scary. And then there's one called Rye syndrome. So individuals who have influenza should not be given aspirin. That leads to Rye syndrome, leads to liver and brain damage. So if you're going to try to bring someone's fever down, Tylenol is fine, but aspirin's a no-go, particularly in kids. Forget the age group, but we do have antivirals, things like Tamiflu, but you have to, of course, take Tamiflu before you know you're super sick. And so then, of course, the vaccine is adjusted each year to try to hit whatever those targets are. We watch what goes on in the Southern Hemisphere during their flu season, and then we try to match those circulating strains. I will say the flu vaccine we've had a few years where it's been super ineffective, like 40% effectiveness, but there's also some indication that even if it doesn't prevent you completely from getting sick, that it can make the disease state more mild. So particularly in the elderly who are high risk, that can be really important. But of course, if we can get more people to not be able to carry and transmit influenza, we can really knock back some of those numbers of infections. And then I'm going to wrap up with the common cold here, right? So the common cold, it's a viral infection of the nose, the sinuses, the upper airways. About half of common cold cases are caused by this critter right here, the rhinovirus, but there's other coronaviruses, enteroviruses, the respiratory syncytial virus, adenoviruses, etc., right? So there's a variety here. But quite often the rhinovirus, it thrives in cold air, right? It likes the temperature of your nasal passages, which are slightly lower than body temperature. It's like 35 degrees Celsius instead of 37, right? There you go. A different niche, a different microbe wants to live there. It is transmitted through those airborne droplets, direct contact, fomites, so sharing, a drinking glass or something like that. So signs and symptoms, we've all been there: sneezing, sore throat, runny, stuffy nose, mild aches and pain, cough, that sort of thing, right? It's a mild illness. It's more of a nuisance than anything. Though, of course, this year, any of those signs and symptoms could be COVID, so it becomes more than a nuisance. You have to go get tested. But the rhinovirus itself, common cold itself, is not going to be life-threatening. And then this may be my favorite image from your chapter here, kind of this summary at the end, because what they've done here is they've gone through different regions of the respiratory tract, pointed out what illnesses are common there. Here's tuberculosis in the lungs, right? And then they point out the causative organism and have color-coded whether that's bacterial, viral, or fungal. So that's kind of a nice one as well as those tables that really go through each of the different disorders and what kind of organisms and virulence factors. So think about how you want to use this, but that is what I am covering. Enjoy.